ফর আওয়ার বডি। তাহলে বডি কি করবে? বডি চাইবে যে এটাকে কোনোভাবে এক্সক্রিট করে দিতে, কারণ বডির ইনবর্ন মানে ডু হ্যাভ ইউ হার্ড দ্য নেম অফ অ্যাডিটিভ, অফ প্রিজারভেটিভস, পেস্টিসাইডস, ড্রাগ ইটসেলফ ইজ অ্যান্টিবায়োটিক্স। ওকে, আমরা ড্রাগ খাচ্ছি, ওষুধ রোগ হচ্ছে, ওষুধ দিচ্ছি, তাহলে বডি কি করবে? এটা কি মজুত করবে নাকি? তা তো নয়। তাহলে সেই পারপাসটা সলভ করার কাজই হচ্ছে মেটাবলিজম অফ জেনোবায়োটিক্স। ওকে, so now the term has changed and it is now called biotransformation. So what is the definition of biotransformation? Biotransformation is a series of reaction that occurs in our body to detoxify the substance, foreign substances or compounds, and to easily excrete from the body. Okay, বুঝা গেল? What are the substances? It may be for exogenous and endogenous. Exogenous substances are drugs, pesticides, additive, okay, and endogenous some substances or compounds are produced in our body in large intestine by the bacteria, which like indole, phenol, tyramine, which are also injurious for our body. Have you heard the name of bilirubin? Yes. Where from it is produced, or by which metabolism we can get bilirubin? Why? Bilirubin কোথা থেকে তৈরি হয়? হ্যাঁ, জোরে বল। Liver is a site of production, site হচ্ছে liver, but from which mother molecule কি? Heme, exactly, মানে গ্লোবিল পোর্শন থেকে, হিমের মেটাবলিজম থেকে bilirubin. Bilirubin itself a toxic product. No, do you know it? No. বাচ্চাদের দেখেছি, ছোট বাচ্চাদের যারা নিওনেটাল পিরিয়ড কাকে বলে জানিস? নিওনেটাল পিরিয়ড পড়িস নি এইচএসে? Early 28 days of birth is known as neonatal period. It has two phases: early neonatal period 7 days and late neonatal phase 7 to 28 days. তো বাচ্চাদের দেখেছিস যে, তোরা গ্রামের কে কে আছিস? তুই? ও, তো বাচ্চাদের দেখিস নি চোখ হলুদ হয়ে যায় ছোটকালে, ঠাকুমা দিদিমারা তেল মাখিয়ে রোদ্রে রেখে দেয়। এটা হচ্ছে যে ফিজিওলজিক্যাল জন্ডিস বিলিরুবিন এক্সেসের জন্য হয়। ঠিক আছে, তো বিলিরুবিন ইটসেলফ এ টক্সিক প্রোডাক্ট ফর আওয়ার বডি। ঠিক আছে, কেন কি হয় বলতে জানিস? জানার কথা না তোদের। খুব যদি বিলিরুবিন বেড়ে যায়, মোর দ্যান 20 হয়ে গেলে আমাদের ব্রেন এফেক্টেড হয়, কার্নিক টেরাস কন্ডিশন হয়। এটা হচ্ছে যে তখন হচ্ছে যে ফ্যাটাল কন্ডিশন। এক্সচেঞ্জ ট্রান্সফিউশনের নাম শুনেছিস? তখন ব্লাডটা চেঞ্জ করতে হয় আর কি। যাই হোক, এত জানার দরকার নেই। Next, I am coming to site of detoxification. Oh, why it is the term detoxification has replaced by biotransformation. Earlier it was think that all the compounds produced by detoxification reaction are less toxic or more or easily excretable from body. But later on it was seen that some substances or compounds produced from the biotransformation are also more toxic than the parental compounds. That's why the term detoxification has been replaced by biotransformation. As for example, procarcinogen. Have you heard? হচ্ছে মেনলি ফেজ টু রিয়াকশন নিয়ে আছে কনজুগেশন হয়, ঠিক আছে, আমি পরে বলছি কি কি কনজুগেশন ইয়ে হয়। নেক্সট আই এম কামিং টু ফেজ ওয়ান রিয়াকশন। অ্যারোমেটিক অ্যালকোহল, aliphatic and aromatic alcohol, aldehydes, amines takes parts in the undergoes phase 2 reaction, ঠিক আছে। phase 2 reaction mainly occurs by the catalyzed by the monooxygenase or cytochrome P450 oxygenase enzyme. Cytochrome P450 also known as mixed function oxidase enzyme. It is present in the microorganism microsome. Main enzyme of phase 2 reaction is oxidation which catalyzed by the enzyme monooxygenase or cytochrome P450. You may get a short note on P450. Okay, clear? Achha, main idea of phase 1 reaction is to produce more soluble products by adding hydroxyl group to aliphatic or aromatic compounds like এগুলো মুছে দিলাম। Cytochrome P450 is, you may get a short note on it. Okay, it is the main enzyme system for phase 1 reaction or oxidation reaction. Mainly phase 1 reaction completed by oxidation reaction. Okay, আচ্ছা, যদি শর্ট নোট আসে P450 তাহলে কিছু জিনিস লিখতে হবে, সেগুলো হচ্ছে যে it has some salient features of P450 enzyme. First, it has 2 to 20 subtype of P450 enzyme or monooxygenase enzyme. Okay, it is a heme protein contains heme as prosthetic group. Next হচ্ছে mechanism of action of cytochrome P450 is complex and needed NADPH. ওখানে দেখ NADPH লাগছে, ঠিক আছে, দেখেছিস, ঠিক আছে, ওকে। আর একটা হচ্ছে ইট ইজ ইনডিউসিবল, মানে এর অ্যাক্টিভিটি ক্যান বি ইনক্রিজড বাই সাম ড্রাগ লাইক ফেনোবারবিটল। ওকে, নেক্সট আই এম কামিং টু ফেজ 2 রিয়াকশন। তাহলে ফেজ 1 রিয়াকশন বোঝা গেল। ফেজ 1 রিয়াকশনটা মেনলি অক্সিডেশন দ্বারা হয়, আর এনজাইম হচ্ছে মোনো অক্সিজেনেজ অর সাইটোক্রোম P450. সাইটোক্রোম P450, you may get a short note on cytochrome P450. ওকে, আর কী কী হয় সেটা তো বুঝলি, কী রিয়াকশান হয় সেটাও বুঝলি। নেক্সট আই এম কামিং টু ফেজ 2 রিয়াকশান। ফেজ 2 রিয়াকশানস, in phase 2 reaction foreign compounds are associated with the compounds produced in the some compounds produced in the body like glucuronic acid, glycine, cysteine, glutamine, methyl group, sulfate group, acetate, thiosulfate. At least 8 compounds are produced in the body to detoxify. To detoxify the foreign substance. Conjugation may occur directly with the compound or after the reaction of phase 1 reaction. তুই ওই পাশে দেখ, এই পাশে দেখ, মুছে দিয়েছি। রাইট সাইডে ছিল ডাইরেক্ট কনজুগেশন হচ্ছে, বডি থেকে এক্সক্রিট হচ্ছে। লেফট সাইডে ছিল হাইড্রোলিসিস হচ্ছে, অক্সিডেশন হচ্ছে, তারপরে নেক্সট গিয়ে হচ্ছে কনজুগেশন হচ্ছে, তারপরে এক্সক্রিট হচ্ছে, ঠিক আছে। মানে দুটোভাবেই হতে পারে, একটা ডাইরেক্টলি হতে পারে আর ইনডাইরেক্টলি ফেজ 1-এর পরে ইয়ে হতে। আচ্ছা, 8 অ্যাটলিস্ট 8 সাবস্টেন্স হচ্ছে আর কম্পাউন্ড হচ্ছে। এক হচ্ছে গ্লুকোরোনিক অ্যাসিড। গ্লুকোরোনিক অ্যাসিডের কম্বিনেশনে কি ডিটক্সিফাই হয় বলতে একটা নাম, এনিওয়ান? বিলিরুবিন, এক্স্যাক্টলি, আমি এটাই জানতে চাইছিলাম। বাচ্চাদের হয় না, কারণ কি এই কনজুগেশনটা হয় অ্যাকচুয়ালি গ্লুকোরোনাইল ট্রান্সফারেজ এনজাইম। বাচ্চাদের লিভার ম্যাচিওর হয় না বলে এই এনজাইমটা কম থাকে। দ্যাটস ওয়াই বিলিরুবিন ক্যানট বি কনভার্টেড ইনটু bilirubin glucuronide. That's why unconjugated bilirubinemia or unconjugated hyperbilirubinemia occurs, which is known as physiological jaundice. ওকে, অনেক কিছু পড়িয়ে দিলাম তো, পরবর্তীতে বাড়ি গিয়ে ডাক্তারি করতে পারি অ্যাটলিস্ট। আচ্ছা, যাই হোক, গ্লুকোরোনিক অ্যাসিড কম্বিনেশন মোস্ট কমন in case of phase 2 reaction. Active form is UDP, glucuronic acid produced in the by the uronic pathway. Uronic pathway পড়েছিস তোরা? হ্যাঁ, পড়িস নি? মেটাবলিজমে পড়িস নি? ইউরেনিক পাথওয়ে পড়েছিস? পড়িস নি? তোদের অবস্থা আমাদের থেকে, মানে আমাদের অবস্থা তোদের থেকেও খারাপ ছিল। মানে আমরা খুব একটা ইয়ে ছিলাম তা নয়। আমি অ্যাকচুয়ালি আরজিগড় থেকে MBBS MD দুটোই কমপ্লিট করেছি। তো আমাদের সময় তো এরকম ছোটো ছোটো স্যারেরা ছিল না, ওই নিচের ক্লাসের টিচার ছিল না, সব বড় ক্লাস। তো তাদের সঙ্গে কথাবার্তা বলাটা খুব একটু টাফ, ভয় ছিল আগেকার দিনে। তো যাই হোক, এবার এক্সক্রিশন অফ দ্য প্রডিউসড প্রোডাক্ট। এই যে বডিতে মেটাবলিজম হলো, সব কিছু হলো, এগুলো তো এবার এক্সক্রিশন করতে হবে, নাহলে বডির লাভ কী হলো, তাই তো? Yes or no? তাহলে মেন অর্গান associated with the excretion of the metabolic compounds is কোনটা? Kidney. Kidney is the main excretory organ of the body that excrete most of the compound produced by the metabolism by phase 1 and phase 2 reaction. Some portion is excreted by feces or expired air. That is okay. All about your genobiotics. কিছু জিজ্ঞাসা আছে এখানে? কারো কোনো কোশ্চেন? ব্যাপারটা বুঝলি কি, মানে ধর একটা শর্টকাট আসবে, খুব সম্ভবত জেনোবায়োটিক্স থেকে একটা আসবে, কারণ আমরা এর ইম্পর্টেন্স বুঝতে পারছি না। ও যে লিপস্টিক লাগাচ্ছে বা আমরা যে ড্রাগ খাচ্ছি সেটার কি হচ্ছে, আমরা কার্বোহাইড্রেট খাচ্ছি সেটা নিয়ে মেটাবলিজম হচ্ছে বিরাট কিছু। এটা আমার যেহেতু বডি পার্টে লাগে, মানে বডি অ্যাক্টিভেট করার জন্য, মানে চলাচলের জন্য লাগে, সেই জন্য এটা মেটাবলিজম নিয়ে পড়ছি। কিন্তু অ্যাকচুয়ালি যে ফরেন বডিগুলো আমাদের দেহে ঢুকছে আর কি, সেটার মেটাবলিজম খুব ইম্পর্টেন্ট। দে আর অল টক্সিক টু দ্য, মোস্ট অফ দেম আর টক্সিক ফর আওয়ার বডি। দ্যাট ওয়াই মেটাবলিজম অফ দ্যাট সাবস্টেন্স আর ভেরি ইম্পর্টেন্ট। ওকে, বাট উই ডোন্ট থিঙ্ক অ্যাবাউট দ্যাট। ঠিক আছে, আমরা প্রতিদিন পেস্টিসাইড খাচ্ছি, তাই তো? ফুডের সঙ্গে যে জিনিসগুলো যায় সব তো প্রিজারভেটিভ দেওয়া থাকে, তাই না? এগুলো মেটাবলিজম খুব ইম্পর্টেন্ট, বুঝতে পারছি? এগুলো না জানলে হবে না, পড়বি। আর সাইটোক্রোম P450, ইট ইজ অ্যান ইম্পর্টেন্ট শর্ট নোট ফর ইউর এক্সাম। খুব বেশি নেই সাইটোক্রোম। আর একটা হচ্ছে যে ওই তোরা কিন্তু কেউ জিজ্ঞাসা করলি না যে P450 কথাটা কেন এসছে আর কি, হোয়াই দ্য 450। এটা হচ্ছে যে কার্বন ডাইঅক্সাইডে যখন এক্সপোজ করা হয় এনজাইমটাকে, ম্যাক্সিমাম অ্যাবজর্বেন্স অকার্স অ্যাট অন দ্যাট ন্যানোমিটার ওয়েভলেন্থ, দ্যাটস ওয়াই ইট হ্যাজ দ্য টার্ম 450। এটা বইয়ে আছে, সবই বইয়ে পাবি, একটু পড়াশোনা করতে হবে। পড়াশোনা তো হয়নি, পুজোর ভিতরেও হয়নি, আর এখন হয় না। প্রথম MBBS এর পরে বাড়ি যাচ্ছিস, পুজো টুজো গেল। আমাদের সময় তো আরও বিরাট ব্যাপার ছিল, মানে আমি তোর 97-এ ব্যাস, 97-এ MBBS ঢুকেছি, তো আমি আরজি করের স্টুডেন্ট। তো সেই সময় তো একটা এগুলো হচ্ছে মানে বিরাট ব্যাপার, মানে ওই সময় ডাক্তারি, আজ থেকে 25 বছর আগে ডাক্তারিতে চান্স পাওয়া মানে বিরাট ব্যাপার। আমাদের সময় কজন স্টার পেয়েছিল? খুব কম। আর এখন তো সবই স্টার। তো নো ডাউট, বাট দ্য life of a doctor is very complicated, and it is going to be more complicated day by day, because the seats have increased. Probably yesterday 100 seats are also increased by the government hospital at Jhargram Medical College. So the tough competition is going to happen in your life. Till now we are a student. After 25 years or 20 years 22 years after completing my MBBS, till now I am a student. So you can imagine how hard your life is going to be. Okay, so be prepared for that. Very competition life আসছে তোমাদের। ডাক্তার is not so smooth thing. ডাক্তারিতে consistency is very essential. ব্রিলিয়ান্ট হওয়ার দরকার নেই, দরকার আছে কনসিস্টেন্সি। তুমি লেগে থাকো, পারবেই। ঠিক আছে, তোদের লাইফ খুব কঠিন হচ্ছে, কারণ আমাদের সময় স্টুডেন্ট ছিল 755, 97 ব্যাচ আমি। ইট ইজ 25 years past. Now government hospital intake is 5,000 along with private medical college intake. Can you imagine how many times that it has increased? So be prepared for that. Otherwise it will be very tough journey for your life. Okay, that's enough.
It is known as platysma, which is present in the superficial part, and this particular muscle is supplied with the branches which is coming from the cranial nerve number 7, and which has a 5th division of this particular 7th cranial nerve, which is a cervical branch. That cervical branch supplies to it and supplies this entire thing. More prominent in male individual, because these particular muscles are more used by male individuals while shaving or trimming the hairs in the beards, etc., etc. And on top of that you can see a vein which is lying on it, which is known as that external jugular vein, which is basically embedded on this investing layer and lying into this particular top of this particular platysma. This platysma from the bottom coming from this particular top of the clavicle, moving up, heading to this particular mandible and moving little bit up and reaching to this particular angle of this particular mouth, and this is ending and investing this particular entire front of the neck. And the back side you can see it is not covering the entire length. Now going to this particular region, which is of concern to us is triangles of the neck. We know that this is having two triangles of the neck, anterior and posterior, split by this particular muscle, which is the SCM, sternocleidomastoid. You can see this particular sternocleidomastoid has a lower attachments and have an upper attachments. Lower attachments is on the sternal part and as well as clavicle. We call them as sternal part of the sternocleidomastoid and this clavicular part of the sternocleidomastoid. And you can notice many of these particular individuals, these two muscle fibers at the bottom has a triangular shaped gap. So we call this particular triangular gap for this supraclavicular triangle, and this particular supraclavicular triangle region may be used for doing interventions in the neck region. And it moves up obliquely, spiraling and going into the back side of the ear on the bone over here, which is mastoid bone, where it is ending over there. So we have right and left sternocleidomastoid. We have to know the nerve supply to this particular muscle, which is supplied with the spinal accessory, which is the 11th cranial nerve, which is supplying to it. And along with this particular sternocleidomastoid, this particular spinal accessory also supplies the back muscle, which is known as trapezius. So these are the two muscles which are supplied to these particular regions. Now the functions of this particular sternocleidomastoid, once this contracts, turns the head to the opposite side, as well as it turns this particular head up its direction as well. So when this particular right side contracts, this particular chin drops down to the neck and it's moving up opposite side. So it is turning the head and as well as making the face go upward directions. Whenever it is contracting bilaterally, both of the side contracting, it's moving the neck up. So whenever you are just like seeing something in deep inside, then both of these are working. So unilateral contractions, bilateral contractions make two different actions to the neck. That's what you have to do, just like understand and reflect. But more importantly, you have to identify this. It should be exam tagged. This could be like asked about the nerve supply. And the second thing, you have to know about this particular muscle actions, unilateral contractions, bilateral contractions. If you cannot make out all the difference of them, just like think about it like unilateral and making this particular muscle contract. And this particular muscle is one of the landmark muscle in the neck. That's what we identify. Now this particular muscle splits this particular triangle in front, anterior triangle, on the back side, posterior triangle. Posterior triangle split into two parts by this inferior belly of omohyoid into the upper bigger triangle, we call them as occipital, and the lower triangle we call them as omoclavicular or subclavian triangle. So these are the two triangles which are present in the back side. And posterior limit by this trapezius, anterior limit posterior border of the SCM from this particular top to bottom, and below it is limited by this clavicle, and on the top is occipital bone and this particular mastoid process of this particular temporal bone, which is limiting in this particular region. Now whenever you are seeing this particular posterior triangle, we have two side triangles, and this particular posterior triangle have got floors. That means it's have got layer with the muscles which is present on it. So from the upside to downside there are several muscles. Splenius capitis, levator scapulae, scalenus posterior, scalenus medius, and in the front anteriorly, not the floor, we have this scalenus anterior, which is in the front side we have. So these are the few muscles which are basically making the floor overlying on this fascia. We call them as prevertebral fascia. So these are the things we have learned. Moving to this particular anterior triangle, which is lying in front of this particular SCM, limited in the midline by this yellow line, that means it's a midline. On the top we have this chin or jawbone, which is limiting this particular limit of this particular anterior triangle on this side. So we have the different directions on this particular anterior triangle is limited. Now this particular anterior triangle has got several sub-triangles. So you have to know these details of the boundaries, how these things are making, like submental triangle, submandibular triangle, carotid triangle and muscular triangle. We should be able to draw these pictures of them, we should be able to draw the boundaries of them, we should be knowing the contents of them, like the digastric triangle, which is also known as submandibular triangle, limited by these two muscles, and upper limit is by this mandible. This particular muscle, which this particular triangle in the front side, limited by the superior belly of omohyoid, midline, and the lower limit of the sternocleidomastoid, which is lying in the midline, which is making this particular boundaries of this particular carotid triangle, muscular triangle, I'm sorry. This particular triangle we call them as carotid triangle, bounded above by this digastric triangle, posterior belly, and this particular middle part of the sternocleidomastoid, and this particular strap muscle, we call them a superior belly of omohyoid. So you should be knowing precisely about this boundary. So we have talked about this in theory. I'm just like summarizing this particular entire content or entire things about related to it. Submandibular triangle, the contents, main of them you have to know that this salivary gland, lymph nodes, facial artery, facial vein, facial nerve, they are present on it, and the floor is limited by this muscle which is known as mylohyoid and hyoglossus. We'll be seeing this particular muscle, how they are placed. And the content about the submandibular gland. Whenever we were studying this particular salivary lymph nodes, this particular submandibular glands will be coming into it. The nerve supply to this, how this functions over there, how the ducts is working, that's what you have to focus in. Submandibular gland, it could be a important short note along with the parotid gland, which could be given in examinations. Coming from here, carotid triangle, we have the contents which is present in carotid sheaths, which is lying here. Common carotid, which is splitting into internal and external carotid arteries, internal and jugular vein, and as well as this vagus and hypoglossal nerve, which are present as a content. On the back side, we have this sympathetic trunk, which is lying on the back side. Floor of this region is formed by medial and inferior constrictor muscles. So these are the carotid triangle. Submental triangle doesn't have any important content to it, but it is lying below the chin and have got lymph nodes which is present in it. We call them a submental group of lymph nodes. We should be knowing the boundaries of them, and this particular submental triangle shares this common floor along with this particular digastric triangle, mylohyoid. They are making the floor of this particular submental triangle. Muscular triangle, which is lying over here. The strap muscles in the front of the neck, they are lying, which call them as infrahyoid. We'll be coming into it, which is infrahyoid and suprahyoid muscles whenever we are going to talk about the muscles in the neck region. Now, this is what we are coming into, the muscles. We split the muscles in the neck region into two entities. We call them a suprahyoid muscle and infrahyoid muscle. So, the landmark is the hyoid. Above hyoid and below hyoid, we are splitting it. So, we have to know the muscles, the name of them which are present as a suprahyoid muscles. So, digastric muscle, they have two bellies, anterior belly and the posterior belly. So, you have to know this particular digastric muscle which is present in here. Should be able to identify which is digastric muscle in here and as well as in your cadavers, anterior belly and the posterior belly along with it. We have a muscle which is present in the above hyoid, we call them as stylohyoid. So, that is coming from the styloid process of this particular bone and going to end in the hyoid. We call them a stylohyoid. This runs along the posterior belly of digastric. So, if you see this particular posterior belly of digastric where I am rolling this laser over here, along with that in front of that we have a skinny muscle lying in front, which is coming from the styloid process of this particular temporal bone and getting into this hyoid bone. So, this skinny muscle along with this particular posterior belly is known as stylohyoid. There is a muscle which is coming below here, below the mandible on the gynoid tubercle and ending on the hyoid. We call them a geniohyoid. So, here is the geniohyoid which is present in here. You can see this particular geniohyoid in this particular picture. Gynoid tubercle to hyoid straightway. Next is the mylohyoid. They are making the floor of this particular submental triangles, digastric triangle. This is a muscle, we call them as mylohyoid. So, this particular mylohyoid is the muscle which is present in here. This is basically making the floor of the mouth. That means our tongue is resting on this mylohyoid. So, if you lift the chin, you can find this particular muscle which is making this floor of this triangle, which is known as mylohyoid. In your dissections as well, this muscle is visible. So, you should be able to identify this particular as a mylohyoid muscle. Geniohyoid is deeply placed little bit compared to it. So, but mylohyoid could be your exam tags. So, once you have this known to these particular muscles, anterior belly of digastric, posterior belly, stylohyoid and geniohyoid, mylohyoid, you have to know about the nerve supply to it, especially the anterior belly and the posterior belly of digastric, because the anterior belly and the posterior belly are sourced from two different regions, and because of having two different sources, anterior belly is supplied by some cranial nerve, whereas the posterior belly is supplied with some other cranial nerve. So, this difference that you have to know, this anterior belly of digastric supplied with the mylohyoid nerve or nerve to mylohyoid, which is a branch of fifth cranial nerve V3, which is mandibular divisions of the trigeminal. So, this nerve is known as mylohyoid nerve. Also, we call them as nerve to mylohyoid. So, this nerve to mylohyoid supplies two muscles, mylohyoid itself and anterior belly of digastric. Where from this mylohyoid nerve is coming? Is coming from fifth cranial nerve. That means the trigeminal. Trigeminal have got 3 divisions: ophthalmic divisions, maxillary division, mandibular division. That third division, mandibular division, splits into this mylohyoid nerve, and this particular mylohyoid nerve supplies these 2 muscles. Then we coming with the stylohyoid and posterior belly of digastric. They come along. So this posterior belly of digastric and this particular stylohyoid, these 2 are sourced from different regions. So when we will be coming to talking about this neck development, we will be learning how these muscles are coming. So they will be talking once again about the source of these muscles. So this stylohyoid and the posterior belly of digastric, they are supplied from the branches of facial nerve. So anterior belly is supplied with this 5th cranial nerve, whereas the posterior belly is supplied with the 7th cranial nerve. So these differences are of importance. So whenever you are given in the examination to identify, it never stops identifying this object. If I give this exam tag, we are not going to ask about this, tell the name of this muscle, because these are kindergarten questions. We are not going to give you kindergarten questions. So we are going to ask you about something layer higher. Maybe just nerve supply, maybe their actions of this, or maybe that boundaries or something, etc., etc. It could be anything and everything, or maybe there may be series of questions maybe related to it. So one question which will be graded 1 marks, next question will be given some other marks. We have seen this, how these questions are being asked in IDs. So posterior belly and anterior belly, this is having very high importance rates. In the examination, most often we ask about this question. Moreover, where these muscles are anchored in this particular bones like mandible. So anterior belly is digastric, in the digastric groove on this mandible, it is placed in there. The posterior belly of digastric, you see, anchored to the mastoid, the inner aspects of the mastoid, temporal bone. So these 2 attachments again, from there you can come here. So we can go and move to any directions, whatever way we want to test you in examination. So this is how you have to prepare your mind whenever you are studying. It cannot be static, one dimensional. That's like I identify the digastric and you ask me about identify this muscle and I will be getting fast forward. Don't expect that. Anyways, left with this particular facial nerve supply, posterior belly, and this particular stylohyoid. This is one muscle which you are seeing here, which is known as geniohyoid. So genoid tubercle to the hyoid bone, straight muscle, which is supplied through the spinal nerve C1. So this is again important, geniohyoid nerve supply, because it's a kind of exceptional thing. So far these 3 nerves we are seeing supplied with the cranial nerves. This is one exceptional which is supplied with the C1, that means spinal nerve. So that's why again these tidbits of information, so whatever you are getting here on this nerve supply, on this identifying it, they are very important. You have to know and remember and rationalize it, why you are remembering it, what's the speciality about it, why should it be remembered, and why you are going to test this. So these are the muscle, we call them as suprahyoid muscle. Now it comes to the easy muscle, we call them as infrahyoid muscle. They are known as strap muscles. That means they are lying below the hyoid bone. We call them as infrahyoid group of muscles. That means they are attached to the hyoid bone, but they are coming from below hyoid bone and ending on the hyoid. There are 4 such muscles are there. We call these muscles as the strap muscles because they look like strap, the ribbon. They are flat muscles. They are present in the front of the neck region, and we see that sternothyroid, sternohyoid, thyrohyoid. So everything is related to hyoid and going to different directions, maybe hyoid, maybe thyroid bones. So there are different muscles which is there, and along with the omohyoid, which is having 2 bellies, superior belly and inferior belly. So these are the 2 bellies of these muscles here together with this hyoid group of muscles, sternohyoid, thyrohyoid. These are muscles which you should be identifying in your exam for these cadavers, and as well as should be identifying it as supra or infrahyoid group of muscles. Next thing is the same thing, the nerve supply to it. Now focus here, if you see this particular 4 group of muscles, all the muscles which is infrahyoid group of muscles supplied to the nerve which is known as ANSA cervicalis. So the ANSA is a nerve loop which is supplying all these muscles except one, which is the thyrohyoid, which is directly supplied through the C1 fibers. Again C1 fibers, just like geniohyoid, this C1 fibers directly supplies this thyrohyoid. Again, that makes these things special, that makes these things different. So you have to know what are the common nerve supply to this particular strap muscles, where this strap muscles are exactly placed in the neck, in terms of the neck triangles are concerned, and then what are the nerve supply to it, and what are the exceptions of the nerve supply which is related to it. Alright. Now, coming to the actions. Now, there are basic actions which is present to it. So, whenever we are chewing foods, talking, making our larynx or our mouth work, so opening and closing things, or moving this larynx up and down while we are talking, or whenever we are swallowing, so things are moving. So, we need muscles to make these actions. So, this suprahyoid group of muscles which is present above the hyoid pulls up this particular larynx or voice box or jacks these things up. So, this suprahyoid group of muscle pulls this muscle up to this particular close to the mandible whenever you are swallowing, talking or doing something. So, this larynx is moved up by the suprahyoid, and again if you are pulling these things up, you need some muscle to pull it down along with the gravity. So, infrahyoid group of muscles are placing this again to the normal positions. So, this is in short about the actions of these muscles, and how these muscles are innervated, that you have to know what are the actions of them and how they are placed in different regions of the neck in respect with the hyoid bone, above hyoid or below hyoid, and nerve supply to them. Good? Doubts, queries? Suprahyoid, infrahyoid, nerve supply, actions. It could be exam short notes. Write down the names of the suprahyoid muscles with their actions and their nerve supply. 3 mark questions. So, whenever you are asking or asked to answer it, give a schematic picture or whatever the pictures you have along with this particular thing, and actions and nerve supply and the positions of them like this. It should be just like writing a word like introductions, then this the body, and then this clinical thing, and then if possible development if you can write it, not a schematic picture. That is it. That covers up your entire thing. So, every basket is covered in that way. So, this is about the neck muscles whichever you have seen along with the platysma and the SCM and the trapezius in the back we have seen. We have 2 other muscles to know about here. We call them as scalene muscles. There are 3 scalenes are there, 3 brothers, scalenus anterior, middle and the posterior. There are 3 brothers, good, bad and ugly. So, these 3 brothers are there. We have to know about these particular positions of them. Anterior anteriorly placed, middle in between, and posterior is posteriorly placed. These are the 3 muscles which is present in here, which is known as scalene muscles. And these particular scalene muscles, actions of them, when they contract, they twist the neck laterally. So, once the right side twists the leg to the right side, left side, assisted by this SCM. So, the functions of the scalenus muscles out here is to move the neck, and they are also respiratory muscles. They assist in assisted respiration. That means, whenever you need to move the chest is up and big, while running, while breathing heavy, you need extra muscles along with the intercostal muscles, along with the diaphragms. So, we need the chest wall to expand. These 3 muscles are expanding or helping these assisted super ventilations of the chest. So, these particular muscles or scalene muscles are in a sense helping this particular neck to face and accessory muscles of the respiration. If you go back to this particular thorax session, you learn about the diaphragm and movement of this particular assisted or accessory respiratory muscles which are present in the neck, you will get this name. Okay? So, these are the muscles which you are seeing here. A quick clinical thing, we call this as cervical rib. That means we have seen these ribs are coming from these thoracic vertebrae, right, which are anchored to these particular fascias. But in some of the cases, abnormally, we see that the 7th cervical vertebra transverse process may be abnormally large and may look like a rib or an extra rib. So, that particular extra long transverse process of C7 cervical vertebra can function as or can pretend or in a session where it looks like an extra rib, or on the top of first rib we have a rib that makes this particular rib, we call them as accessory cervical rib. Now, what happens if you have an extra rib? Whatever the neurovascular structures that is coming through between the scalenus medius and scalenus anterior, including the blood vessels, could be damaged, ruptured, compressed or traumatized by this accessory rib. So, the nerves which are coming in between the brachial plexus. So, it may be just like a friction, making frictions with the brachial plexus. Maybe your arms may be having uncomfortable situations. Maybe it compressing on this artery which is subclavian artery which is going to supply the blood to the arm. Maybe that is compressing on it. So you may not have a proper blood supply to that particular individual. Arm muscles may be weak. So this particular thing is known as the cervical rib, which is creating a clinical case or clinical syndrome. We call them as thoracic outlet syndrome. So that's the thing which happens if you have an extra rib over there, which is the extra long C7 cervical vertebra transverse process. You do not have to know about this particular disease. You have to know about the anatomy. What wrong is going over here? The wrong is the transverse process of which vertebra? Cervical vertebra. Which cervical vertebra? 7 cervical vertebra. Maybe abnormally long. That long, extra long transverse process of the cervical C7 vertebra, we call them as cervical rib. And that long rib can damage or injure or compress nerves, blood vessels, veins, etc., etc., and creating a disease. That's a problem. Maybe it could be unilateral, right side may be having it, left side may not have it. Or maybe it could be bilateral, both of the side, right cervical and left cervical C7 transverse process may be long. So you may have a bilateral transverse cervical rib which may be present, or maybe unilateral, depending on the patient who will be coming with the complaints of like numbness or tingling or weakness of the arms, etc., etc. Whenever they are making exercise or doing something movement, arm up or arm down, they are having uncomfortable things, which could be one of the clinical things related to it. So this is about the neck muscles and the related thing which is due out here. Several branches are coming out. So one artery, we call them as carotid artery, and carotid artery, which is common carotid artery, splits into two branches, internal carotid and external carotid. And you can see jolly well in the picture is over here is the common carotid which is splitting into yellow and the red. The red one which is going to the brain, serving no branch in the neck region. So its functions is only inside the neck and getting inside the brain. That's why you call them as internal carotid artery. Left here with yellow guy, which is external carotid artery. It is splitting into several branches. That several branches we are going to identify in the neck region, and those branches are going to supply the neck, face and the back region and supply the blood to this particular region. This is one. Other artery, subclavian artery. This is the small subclavian artery you are seeing here, the purple one which you are seeing here. This subclavian artery and getting over here, traveling through the ribs and this particular between the scalene muscles, entering to this particular eventually to the right arm and left arm and supply to this particular arms. Before it reaches to, it supplies the root of the neck with some branches. That's what it is supplying with. So two arteries supplies the entire blood source to the neck region, carotid arteries and subclavian arteries, and the branches of them are coming over here. So we will be taking one after another how do these particular arteries are seen. Subclavian artery, right side and left side, it is having two different sources. Right side, it is coming from a common source, brachiocephalic artery. Left side, it is a direct branch of arch of aorta. From the brachiocephalic artery, it splits into two branches on the right side, common carotid and then right subclavian. This right subclavian and left subclavian serves several branches in this particular neck region or root of the neck region. So this particular artery, which is subclavian artery, once it crosses the first rib, it changes the name. It becomes the axillary artery. Once it crosses the teres major muscle, it changes the name. We call them as brachial artery. Then it goes down to the arm, splits into radial artery, ulnar artery and supplies the entire arm. Now our concern is here the subclavian artery in the root of the neck region, just little courses over there. In this particular region, it supplies several branches. This subclavian artery in this root of the neck region, it's having three parts. First part, second part and the third part. So each of these particular parts, it gives several branches. From the first part, it gives a branch, we call them as vertebral artery, thyrocervical trunk and internal thoracic artery. Second part gives a branch, we call them as costocervical trunk. And from the third part, it gives a branch which is known as dorsal scapular artery. So these are the several branches which is coming from the subclavian artery. So first part, second part and third part, and this particular arteries having several branches. Now in short, we have to memorize these particular branches which is coming from this particular different branch or different parts of subclavian artery, we have a mnemonics to memorize to start with. We call them as vitamin C and D. So VIT CD is a mnemonic from the branch to memorize in short about this particular subclavian artery. So V for the vertebral artery, I for this particular vertebral artery which is coming out here, I for inferior thyroid artery which is coming over and supplying to this particular artery, and C is the thyrocervical, I is this particular internal thoracic artery, and this T is the thyrocervical trunk. So this vitamin, which is in short we call them as VIT, which is a branch which is coming from this particular first part of the subclavian artery. Vertebral artery is V, I for internal thoracic artery, and this T is thyrocervical trunk. Now thyrocervical trunk is giving the branches which is going to supply the bottom part of the thyroid, which is known as inferior thyroid artery. So this branch of this thyrocervical trunk, at least you memorize out of these particular sub branches coming from the VIT. Now from the second part, it gives the branch which is known as the costocervical trunk, which is VIT-C, which is coming from the second part. And the third part is giving the branch which is known as dorsal scapular artery. So these are the branch which is coming from these different parts of this subclavian artery, first part, second part and third part. In short, we call them as VIT-CD. So you remember the VIT-CD, and just like remember the name, V by this vertebral artery, I for internal thoracic, T for thyrocervical trunk, C for costocervical trunk, and D for dorsal scapular artery. So this is how you just like memorize. Later on you just like practice and rehearse this thing, the entire name branches, you can just like figure out. And with this picture you can see this, which artery you can see that. The number 1 is aortic arch, 2 is the brachiocephalic trunk, 3 is the right communal arteries, and this particular subclavian artery is number 5. Then it gives a branch which is going up over here, which is a vertebral artery, number 4, which is going up and going to supply. The vertebral artery goes in the brain eventually. So 6 is this particular branch which is going to supply the thyroid, thyrocervical trunk. 7th one is going to this particular thorax. We call them as internal thoracic artery, which is lying on the inner surface of this rib cage. And then we have the 8th branch which is costocervical trunk and dorsal scapular artery. So in short, V and CD. So this is the entire branch which is coming from the subclavian artery. Now, these are the branches what you are seeing here. If you have exposed by any chance seeing this entire thing dissected with a deep neck dissection, so you can see this particular branch is going on. And you see this branch which is known as vertebral artery is going through the vertebra and transverse process of the thoracic vertebra. If you remember that the transverse process of the thoracic vertebra have a hole in it. We call them as foramen transversarium. It runs through the foramen transversarium, this artery which is the vertebral artery. So this is the reason of knowing this particular vertebral artery and the transverse foramen in the transverse cervical artery, transverse foramen in the cervical vertebrae. So this is how it is going through the vertebral transverse process, moving up right side and left side and uniting here in the midline, forming an artery, basilar artery. Then it forms a circular part, we call them a circle of Eulis. Whenever we are done with the neck, we will be coming to teach about this blood supply of the brain. So then in the brain, this vertebral artery will be starting once again, and the circle of Willis, which could be an exam short note in the brain region, which you will be learning. But anyways, we are just like keeping this thing short out here. So this is about the subclavian artery. Now coming to this particular artery, which is known as common carotid artery. So common carotid artery, right side and left side have got different sources. Right side it's coming from the brachiocephalic trunk, left side coming from the direct sources. Then this common carotid artery is splitting into two branches, internal branch and external branch. Internal one going to the carotid opening and getting inside this brain through the carotid canal and supply to the brain. We'll be learning that carotid artery, internal carotid artery whenever starting the brain. External carotid artery, which is of our interest. The divisions of this particular thing is taking place around the superior border of the thyroid cartilage. You see this particular larynx. This part of the larynx we call them as thyroid cartilage. If you just extend the neck in front, you see that there is a prominence over here. So this particular prominence we call them as thyroid prominence, also known as Adam's apple. So this particular Adam's apple is this one. So this is basically thyroid cartilage which you are touching. So on the top of the thyroid we have hyoid, below the thyroid cartilage we have this one, we call them as cricoid. So these three, hyoid, cricoid and this particular cricoid, thyroid, hyoid together with these other few cartilages makes this particular larynx or voice box. So this particular larynx superior border, where you can see the split of this particular carotid artery takes place into internal and external carotid artery. So this particular carotid artery often used to take up the carotid pulses, and we recommend this whenever you are taking the carotid artery pulses, take the pulse of one side, because if you are pressing this artery, you are basically stopping the blood flowing through the carotid arteries. That means you are stopping the blood going to your brain. So the patient may faint if you are taking the carotid artery pulsation at the same time, especially in some individual where we have a carotid artery which is hypersensitive, they may faint out. In physiology session, whenever you are taking the pulses, they must have like mentioned about these particular entities. But coming to the branches of the external carotid artery, this is what you have to memorize. So what are the branches that is coming from this external carotid artery, you have to memorize, along with the branches of subclavian artery which I mentioned, BIT, CD. Those are the sub branches you have to know. So this particular first visible branch of this external carotid artery, which is superior thyroid artery, lingual artery going to supply the tongue, facial artery going to supply the face, pharyngeal artery which is a deep placed artery going to supply the pharynx, occipital artery going to the back side and getting the supply in the back side, posterior auricular and a maxillary artery which is going to supply deep inside this particular maxilla, and superficial temporal artery which is lying superficially in front of the tragus. We take the pulsation from there. So this particular splitting of the artery is visible like this. So you see this carotid artery, common carotid, which is splitting into two branches, internal and external. External one, this one, it gives a branch which is having a downward course. This is superior thyroid artery, you can see going to supply the top part of the thyroid. Then this artery is coming, have these common sources over here. So this is known as linguofacial trunk. It splits into two branches, facial artery and the lingual artery. So this one which is going to supply this particular tongue, which is known as the lingual artery. Next one which is going and having a spiral course entering this particular facial artery. This is the occipital artery going in the backward direction, going to this particular mastoid bone. Pre-auricular, post-auricular artery which is little bit higher in a position over here, going behind this particular region, and then it splits into two branches. It is deep one which you seeing here, maxillary branch which is one of the terminal branch, and this one is superficial temporal artery. The superficial temporal artery pulsation of that can be picked up in front of the tragus. In here you can see the pulsation. That pulsation of the superficial temporal artery can be picked up here along with the pulsation of the carotid arteries. So these branches of this particular external carotid artery you must be knowing. There may be questions giving and asking about, narrate the branches along with the diagram to discuss about this external carotid artery or sub branches of it. Thyroid artery, lingual artery, facial artery, ascending pharyngeal, occipital, posterior auricular, maxillary and superficial. These are the branches, and they supply this area, larynx, hyoid muscles, thyroid, tongue, facial region, pharynx, occipital, back of these regions, scalp region, maxillary, going to supply deep inside this particular jaw region. Over here is superficial temporal, which is going to supply the face and the scalp region. So this is what you have to know about this particular branches of this, and you must be seeing some of them or couple of these branches of the external carotid artery which is present. Again, in an examination, if you find any artery visible over here and we tag it, don't expect that we will be restricting our question on it. So we may be asking about, write down all the branches of the external carotid artery, emphasizing on something else. Alright, so that's why you see that if you have given a superior thyroid artery to tag with, we may be asking about the other branches of the thyroid artery, which is inferior thyroid artery, where from it is sourced and how it is coming and how these things is related to in respect to the nerves which is supplying along with these thyroid gland. So those things are very related or interrelated in the neck region. Coming to this one, what I am mentioning over here, this is what we have to know about thyroid gland. It is supplied with the two sources, superior thyroid artery, inferior thyroid artery. Superior thyroid artery is sourced from the external carotid artery. Inferior thyroid artery is sourced from the thyrocervical trunk. The thyrocervical trunk is coming from bit C. That means the second branch of the subclavian artery. Thyrocervical trunk is coming from this inferior thyroid artery. splitting in inferior thyroid artery, which is supplying the bottom side of the thyroid gland and supplying to it. Accompanying these two arteries, we have two nerves. We have the laryngeal nerves, which is coming from above and coming from below. The nerve which is coming from below, we call them as recurrent laryngeal nerve. The nerve which is coming from above, we call them as superior laryngeal nerve. So these are the two branches of the laryngeal nerves, they are coming from it. So we should be knowing about these particular laryngeal nerves very well. So we have a nerve which is known as 10th cranial nerve. What is the name of the 10th cranial nerve? What is the name of the 10th cranial nerve? Vagus. Alright, so vagus is nerve number 10 and it is placed in which triangle? Carotid triangle. So this vagus splits down into several branches. One of the branches of the vagus going to supply to the larynx. We call them as laryngeal branch. And one of the branches of the vagus, like many other branches supplying the pharynx, we call them as pharyngeal branch. So these are two branches. Now out of these we focus these laryngeal branches. There are two laryngeal nerves are there. One is known as the superior laryngeal nerve, other is known as recurrent laryngeal nerve. Now why do we call them as recurrent laryngeal nerve? Because that particular nerve are sourced or coming out from a nerve, then it is going up. So as if it is sourced from bottom and then it is crawling up. So it is having a recurrent course, that means moving up from this origin. That's why you call them as recurrent laryngeal nerve. It is recurring, right? So it is coming back, something like that. Recurrence of the infections, just like that. So this particular nerve, which is a recurrent laryngeal nerve and the superior laryngeal nerve, what do they supply? They supply the larynx. Now in the larynx there are two entities. One is sensory, one is motor. That means to move the muscles of the larynx, we need a nerve supply. That's a motor branch. And as well as to pick up the sensation inside the larynx, the cough. That thing also needs a nerve supply. That means sensory thing. So this vagus, branch of vagus, which is laryngeal nerve, superior and recurrent, they supply the larynx both motor plus sensory. Getting it what I am trying to say? So they are supplying both of these entities, the sensory supply and the motor supply. Now we take this particular branch which is known as superior laryngeal nerve. The superior laryngeal nerve having two sub-branches. At this point I am just like introducing this thing. The superior laryngeal nerve again splitting into two branches. One is known as external laryngeal, other is known as internal laryngeal. So this one is external laryngeal, which is coming from the superior laryngeal nerve and is known as internal laryngeal nerve. Now what is external is working here? This is a motor branch. And what is internal is getting inside the larynx, this is a sensory branch. So we focus at this level only. Laryngeal branch, two of them. Superior, recurrent. So focus the superior one, which is related to here. That's why I am saying it has two sub branches. One is getting inside the larynx, supplies the sensation. That means cough sensation, everything, whatever choking sensation, whatever sensation you are feeling inside the larynx because of any foreign bodies or anything, cough or any mucus, those things are picked up by the sensory nerve. That means this internal laryngeal nerve, which is a sensory branch, and motor branch, which is known as external laryngeal nerve, which is supplying some of the muscles of the larynx. That means it is moving the larynx. That means voice production is related to the productions of the voice. So these two things should be very clear about it. Are you clear with this, whatever I am saying or not? What is internal is meant for, what is external is meant for. Clear? If it is in, that means sensory branch. If it is externally placed, that means it is supplying the muscles. Alright? Now out here, we have a branch, you see that, the external laryngeal nerve. You see that? So this particular external laryngeal nerve follows this artery, which is known as superior thyroid artery. Compared to here, in case of this thyroid artery, which is coming from below, inferior thyroid artery, accompanied by a nerve which is coming has a recurrent course, which is known as a recurrent laryngeal nerve. The recurrent laryngeal nerve, just like superior laryngeal nerve, also have the sensory branch and as a motor branch, right? So we'll be learning about the vagus nerve. We'll be learning about these particular subdivisions of this sensory and the motor. What muscles are supplied by superior laryngeal? What muscles are supplied by the recurrent laryngeal? I'm not going to talk about the detailed things, just introducing these things. Now these two nerves followed by these particular arteries, these things we have to memorize. Why? If you have a diseased thyroid, you have to do a surgery of removal of this gland. To remove this gland, we have to stop the blood flowing through the gland before taking it out. So we stop this artery, right and left, superior and the inferior thyroid arteries. While we are stopping this blood supply through it, we have to be mindful not to damage the nerve which is accompanying to it. So if you damage this nerve accompanying these arteries, while doing the surgery of removal of gland, what we are going to miss? We are going to miss the sensory supply or motor supply of that particular larynx. So a patient maybe have a very successful thyroid surgery but losing the voice. But despite doing a very successful surgery, you will be given a huge amount of the compensation in the law of court. Maybe whatever you have learned in your life that may be washed away. That's why you have to be careful about these two nerves, and it's mindful. That's why we're starting at the beginning. There will be no excuse that these are an operational error. It could be happening. It's accident. No, this cannot be just like considered as accident because it's starting from the bottom or beginning of this MBBS career. You cannot defend that in the law of court. Anyways, so that's the relationship of these particular nerves along with the arteries you have to take here. And what is the significance of these things or knowledge of these things or matters to here. Superior thyroid, inferior thyroid and the accompanying nerves, recurrent laryngeal and the external laryngeal branch of the superior laryngeal nerve. Now, coming to this particular thing, this is a physiological thing, I escaped that. Carotid sinus, carotid body, aortic sinus, aortic body. These are the physiology short notes, whatever you will learn. Coming to the veins, facial veins, retromandibular vein, external jugular veins, anterior jugular vein, internal jugular vein and subclavian veins. So these are the veins or branches of the veins which you are seeing here, which is present to this particular neck region. So this particular facial vein which starts from this region and as an angular vein comes down into anterior division, posterior division, joins with the vein which is the superior temporal vein, forms this retromandibular vein. The retromandibular vein drains into this particular external jugular vein. So this particular facial vein makes this particular and other divisions of the retromandibular vein which is anterior division makes the common facial vein. This common facial vein drains eventually through these terminal veins into internal jugular vein. So these are the veins which is present in here. So you should be knowing about the veins, how they are formed, what are the retromandibular veins, is significance of in terms of the presence of the retromandibular vein in a soft tissue structure like parotid. What's the relationship of the retromandibular vein along with the artery and the nerves in the parotid region, which is on the anterior side, which is the middle, which is on the posterior or superficial to deep. That must be emphasized in the lecture class on the parotid region. We should be like knowing about. External jugular vein, which is present on the top of the SCM, sternocleidomastoid, in top of the platysma. You have seen that. This is pretty much superficially placed. This is engorged in case of the diseases. If you have the heart diseases, these veins becomes engorged, especially the heart failure patients. Now internal anterior jugular vein. This is present in the front of this particular triangle, submental triangle, submuscular triangle. This particular anterior jugular vein which is present in the front of the neck, and internal jugular vein which is a kind of vein which is part of the content of the carotid sheath, which see here is a continuation of the sigmoid sinus coming from the brain, going down and draining the blood of the brain region front to back and eventually joining with this particular subclavian veins, make this brachiocephalic vein right and left unites, makes the superior vena cava. So this is the thing which is there important to us. These superficial veins are used to access here during catheterizations for the long line. So whenever you are grow up, eventually you will land in the internship or housestopship, we have to do a procedure, we call them as catheterizations. We have to reach to the heart, get to the inner veins to here. So we access these particular veins. The locations of those veins matters that time. So again, you have to come back to your basics. If you have a very poor foundation of your basics, you cannot perform these things and you will be screened out. You are not becoming just like a knowledge of this particular veins, if you cannot capitalize at that particular point on introducing this particular long lines, it will be very troublesome for your career. Now, coming from these particular veins, this is another vein we are talking about, subclavian veins. This particular veins also used for these particular cath operations. This subclavian vein, subclavian artery present in the front of the triangle over here, posterior ones, homoclavicular or supraclavicular triangle which you are seeing here. This particular vein is also used for long line procedures. Lymph nodes, several lymph nodes are present in this neck region. They are present in front of the ear, behind the ear, and in front of the entire neck region, below the mandible, below the chin. Depends on where they are placed. These particular lymph nodes are classified or nomenclatured them. Preauricular, postauricular, occipital group, posterior cervical group, submental group, submandibular group, tonsillar group, etc., etc. So you have to know these particular names, what this particular name signifies, and then just like I have to just like understand accordingly. And the significance of them, once you go to the pathology classes, the next one, then you will be seeing these particular diseases which is getting these particular lymph nodes enlarged, and this particular thing starts from there. So this particular enlargement of the lymph nodes affected by the enlargement of the gland. Say for example, this particular occipital group, this lymph nodes is enlarged. It commonly gets enlarged in case of these particular infections in the scalp region, etc., etc. Now coming to this particular last entity about this particular nerves. We call this nerve as cervical plexus. There is a nerve of this particular thing which is taking place in this particular, in top of this carotid sheath. We call them as ANSA cervicalis. So this ANSA cervicalis is a nerve branch which is present in here, formed by this nerve loop, C1 fiber, C2 fiber, C3. You see this, these are the spinal nerves. They are joining with the C1, C2 and C3 joining together makes a lower root of this ansa cervicalis, a nerve loop, and C1 which is run along with this hypoglossal nerve, and then it splits into two branches. One of these branches goes to supply these two nerves individually, and rest thing is dropping down and meeting with the lower loop of the ansa cervicalis. This loop of the nerve, whatever you are seeing here, we call them as ansa cervicalis. It is lying in the neck region, where in the neck region, in the carotid sheath region or carotid triangle, it is lying. Now what is the functions of this particular nerve loop? It supplies all the strap muscles. So this particular strap muscles, whatever you are seeing here, is supplied over here except one, which is the thyrohyoid. So thyrohyoid is directly supplied by the C1 fibers, so is the geniohyoid. So if you remember that, the nerves we have mentioned, which is supplying the suprahyoid and subhyoid muscles, and the nerve supply to them, we mentioned about geniohyoid has a different nerve supply. It is not supplied for the cranial nerves, and the thyrohyoid is only one strap muscles which is not supplied through the nerve loop, which is known as ansa cervicalis. So these things matters to us about the knowledge of the ansa cervicalis. How these nerve loops are formed, which are the nerve loop participating in formations of this nerve loop, what are the branches coming from this ansa cervicalis, and what are the muscles are supplied by this ansa cervicalis, and what are the muscles which are not supplied by this ansa cervicalis. So these are the things that you have to know about. Coming to this particular nerve point in the neck region. So in the posterior triangle you see this, behind this sternocleidomastoid, there are a bunch of nerves coming here. We have a nerve going across, transverse cervical. We have a nerve going in front of the ear, preauricular. There is a nerve going behind the occipital region, greater occipital. A nerve dropping down towards the clavicle. We call them a supraclavicular nerve, which is splitting into three divisions: medial division, intermediate division, lateral divisions. Along with a nerve which is going from the back side, going to supply this muscle like sternocleidomastoid and trapezius. It is emerging behind this particular region. That particular region we call them as nerve point. So this is the nerve point where from all the nerves are coming. So nerve point is important here because if you want to do any surgery like lymph node dissection or any superficial surgery, we throw the anesthetic drug here and anesthetize the nerve which is coming along. This nerve which is coming over here, this all the branches of the nerve which is coming here, which is going through different directions, upward, transverse, downwards, they are sensory nerves, supplies the skin of entire neck region. So if you are going to intervene the neck region to do any surgeries, we anesthetize these nerve points and do the surgery. So this is about the short thing about the neck region, including these blood vessels, including these nerves, muscles, and the significance of them. So this is the entire summary of the entire thing. Now go to the books, study here, go to the lab. Whenever seeing this cadaver session, cadaver pictures, go to this particular alignment or attachments of the muscles which are present in the neck regions. Any doubts, any queries? Hope not. All right, that's end for us. Thank you.